I'm Yu Ying. I'm excited to share a case that I had on service about a month ago. So our case begins with a 63-year-old female. She has a history of hypertension, hyperlipidemia, CAD SAS post-PCI about 5 years ago. She initially presented with exertional dyspnea and was found to have 3-vessel CAD and underwent a CABG on the same admission. She had a post-op course that was complicated by ARDS, requiring ECMO for a few weeks, and anuric renal failure secondary to ATN. She was on CVVH and developed also HIT, so she was on bivalirudin. And at the time of my consult, she was still on 2 pressors. We were consulted for ongoing coffee ground emesis over the weekend, so this was a Monday ICU case. At the time of the scope, she had a white count in the 20s, which had been elevated for quite a while. Her hemoglobin were still in the 10s, but had ongoing sort of transfusion requirements, and her lactate was 1.4. And so we performed a bedside BGD. So these are the images, and I'll show a video on the next slide. So here you can see sort of diffuse mucosal changes in the stomach. This is sort of in the antrum, the body. It's hard to tell because there's such diffuse, severe mucosal changes throughout. It appeared congested. There was discoloration with ischemic appearing mucosa and ulcerations found in the entire stomach, along with a large amount of old blood, which appeared like hemorrhagic necrosis. So here's a video. So you can just see that there's a lot of blood, as well as sort of the congested, discolorated, and ulcerated mucosa in the stomach, concerning for ischemia, and the blood we thought was the result of this like hemorrhagic necrosis. In this patient's clinical setting, we thought this was compatible with a low flow state versus thrombosis from her HIT. Oh, let me get to the next slide. So this patient was maintained on TPN, remained MPO, and had an NG placed on suction, and she remained on broad spectrum antibiotics. And then when Dave and I were on consults again, sort of 10 days later, we were reconsulted on her for melena and coffee ground emesis. Initially, they had asked us if there was any utility in doing a second look endoscopy prior to reinitiation of PO. And we had, there's not very much a lot of guidance about gastric ischemia, which will be the topic of my discussion. But, we did look through the literature, and, we did suggest that there would be some utility in doing a second look, because in these patients, they often have a poor prognosis, and many of them can develop deep ulcerations. And this is what we saw on our second look endoscopy for sort of repeat coffee ground emesis, and you can really see that the ulceration is now more pronounced, again, with some old blood in the stomach as well. So the topic of my talk today will be gastric ischemia. This is a relatively uncommon entity because there's such a rich blood supply to the stomach. As a review, the main blood supply from the stomach comes from branches of the celiac artery, which provides the main vascular supply to the stomach. The celiac artery is the first major branch of the abdominal aorta and branches into the left gastric, splenic, and common hepatic artery, which then divides into the proper hepatic and gastroduodenal artery. On occasion, the first branch of this superior mesenteric artery, which is the inferior pancreatico-duodenal artery, also provides collateral blood supply. So it's very rare entity, but in terms of what are the most common etiologies of gastric ischemia, it really has to do with sort of systemic hypoperfusion in the setting of shock, sepsis. In Our Lady's case, she was on ECMO for several weeks. And gastric volvulus, less commonly vasculitis, embolism, endoscopic therapies. So I'm going to briefly review a case series that was published in CGH back in 2013 of 6 cases of gastric ischemia. The first table just shows sort of the common findings endoscopically and histology of these cases. We didn't take biopsies in our patient's case. So in animal studies, in terms of the lesions that can appear in the stomach, it can actually happen in 3 to 8 hours in the setting of systemic hypoperfusion or shock, and ulceration may take 1 to 2 days. Histologically, early gastric ischemic changes include mucosal edema, vascular congestion, and superficial necrosis, which were seen in our patient's case. These changes then can progress to mucosal coagulative necrosis with surface erosions and fibrinopurulent exudates, which happened on our second look endoscopy. These ongoing ischemic factors can result in full thickness hemorrhagic necrosis with deep ulcerations of the gastric wall. In almost all 6 of these case series, they saw gastric ulceration, and this is because gastric acid exacerbates and fosters ulceration. A large acid pocket forms around the fundus and posterior gastric wall as a result of ischemic gastroparesis and the supine position of these patients. So this acid pocket actually facilitates the formation of very large ulcers. On our second look endoscopy, our patient's ulcer was actually greater than 10 centimeters. In all of these cases too, they noted a lot of gastric distension, which happens in the setting of ischemic gastroparesis. Gastric distension can both induce and exacerbate gastric ischemia. Very interestingly, all 6 of these cases, none of these patients had mesenteric ischemia or ischemic colitis. So they had relative sparing of the superior and inferior mesenteric arterial supply during the initial insult. But we can talk about that in the discussion, which, this is something that I found kind of interesting. So there are no guidelines in terms of management. So they have a lot of suggestions on what can be done in these patients. Because of the poor prognosis, early diagnosis is advised when possible. The authors believe that it is safe to perform endoscopy in the setting of gastric ischemia, much like in ischemic colitis. It is safe to perform, and the gastric wall is much thicker than the colon, so the risk of perforation is much smaller than those of colonoscopy. Imaging studies may detect gastric error and help out rule out other intra-abdominal causes for the clinical presentation. So if there's any suspicion for gastric pneumatosis, they suggest getting patients on broad-spectrum antibiotics. And as we discuss about gastric distension with food or food accumulation, it can be observed as either a primary or secondary event. And because that gastric ischemia can be exacerbated by gastric distension in the setting of impaired motility and ischemic gastroparesis, the authors recommended intermittent NG suction with IV PPI therapy. In a rat model, they actually found some evidence that getting patients on IV PPI therapy can reduce the overall surface area of ulceration as long as you get them on it within 72 hours. And they just created this table of severity of endoscopic findings of gastric ischemia based on, I guess, these 6 case series. And I would say that, in our patient's case, she had severe gastric ischemia, especially on our second look endoscopy. So just my take-home points that gastric ischemia is associated with a poor prognosis, so early diagnosis with endoscopy can be crucial. There is utility to doing a second look endoscopy if anyone ever were to have a case of this again. In terms of management, the principles are sort of NG placement for suction to relieve gastric distension, maintaining on IV PPI, selective use of broad-spectrum antibiotics if you think this patient is at risk for gastric pneumatosis or if there's sepsis involved, and a surgical consultation, just because ultimately a lot of these patients fail conservative management. Thank you.
Okay. Thank you very much. I would be curious to poll the surgeons. I know there's a couple surgeons listening. How often they've seen this and or have had to take a patient to the OR for management.
Very, very rare to take the patient to the OR for this situation. Almost always gets better on its own.
Can you comment on, whether it's gastric ischemia or necrosis, or sometimes we get for colonic ischemia, those kinds of things. There's always a debate around the safety and utility of doing endoscopy, and I think in general we tend to be a little more cautious because we don't want to create a perforation in a compromised wall or exacerbate what's already there. You have any thoughts or comments on that, Mark?
Yeah, this is mostly a mucosal related injury, and the strength of the wall really is in the submucosa muscularis. And so very rarely will we see perforations endoscopically. I have no problems with you scoping the patient because I'd like to know exactly what's going on so that we don't have to necessarily do anything for that patient.
Yeah, and we didn't have any problems. I mean, we thought about it and came to the same conclusion and decided it would be good to see whether it progressed or not. The problem after that is we weren't sure what we would do next and whether this was going to heal at all. Any chance of it healing. I don't know how she did Yu-Ying after that, but
she's still in the ICU on TPN. So
with the stomach.
With the stomach, yes.
Yeah. Okay. Good.
I have a question. The first time you went in, obviously that was a very frightening looking stomach. And I'm sure because she was bleeding and because she was so sick, the thought was like, let's not take biopsies and rock the boat. But because she was such a sick person, the differential is not just limited to ischemia. Obviously there's like a lot of things it could have been. Was there any consideration of taking biopsies either time?
So the first time, definitely not. There was like a lot of blood in the stomach. The second time around, there was less blood, but it appeared very, I guess, based on her clinical story and just how like necrotic that area looked with ulcerations. We didn't end up to biopsy just because we didn't know if it was like more of a full thickness involvement of the stomach, and we didn't want to risk any perforation.
Yeah, I wouldn't shy away from doing the biopsies either time. I mean, you could have done them the first time. You certainly could have. I mean, we didn't do it the second time, but the first time, particularly like you're saying, Zoe, if there was concern about etiology or what was going on, there's very little risk in taking a couple of mucosal biopsies, really.
I would agree with that. I mean, we had a case not too long ago of a young woman with a post-transplant who had a horrific looking esophagus with very deep cratered ulcers, and biopsies were obtained and non-diagnostic and was referred to us for further evaluation. And we went down and we said, well, there's no real indication for an endoscopic ultrasound. Let's just take more biopsies. And, we went into the ulcer bed and took a bunch of biopsies, and path came back positive. And I remember talking to the folks who sent the patient, like, what did you do differently? And I'm like, we just took biopsies where we thought it was going to be diagnostic and really had very little concern about causing a perforation or anything like that.
That was in the esophagus, not the stomach.
Well, esophagus is even thinner.
Yeah.
Right. That's what I'm saying. You were
That was in the esophagus, right?
Even in the esophagus, that's even thinner. You still felt comfortable taking those biopsies.
I mean, I'm sure the IBD folks can relate if they have a severe, someone with Crohn's disease, Crohn's colitis with severe ulcerations. I would be shocked if there was more than one biopsy-induced perforation or something. I think it's pretty safe to do these things.
Something I would just point out, the GI tract has two layers of muscularis propria, the inner circular and the outer longitudinal, but the stomach has a third layer. The stomach has an oblique layer of muscles because it has to churn and mix the food. So it's an even thicker wall. So you shouldn't be as timid as you might be in other parts of the GI tract.
I would agree with the notion that biopsies are pretty safe. They are really mucosal only. Where I get more worried is the distension and traction and tension against an organ instead. So if you saw a stomach like that, you overinflated it and then said, oh, let me go into the duodenum or proximal jejunum, that distension from the scope, we know that can perforate a colon in a normal situation. And I know that's where it gets nerve-wracking in these really bad, severe UC cases. You limit the extent of your exam because you don't want to have that shaft injury to the lumen.
And we actually talked about that during the second procedure.
Yeah, we actually didn't. I just popped into the bulb and then it was like, come back. So.
I would offer one other etiology to add to the list of causes of this. There was a report a few years ago of a patient with, I believe, pancreatic cancer who was undergoing multiple rounds of EUS-guided celiac plexus neurolysis, where we typically inject a combination of bupivacaine and alcohol in or near the celiac plexus to help manage cancer-related pain. And there's one case report of a patient who developed gastric necrosis. I believe actually there was aortic necrosis associated with it, and they obviously didn't survive this complication, but it was noted, and so rarely things we do can also induce this. I don't think any of us have ever come across that. But, all right, great. Thank you very much, Yu Yang. That was a great case and great discussion. Believe who's our next speaker? Is it Steph? No.
Ji-yoon.
Ji-yoon, sorry. Okay. Is Ji-yoon on? Yep.
Sorry, I'm just trying to figure out how to get Zoom to.
I'm glad everything is okay.
Is that what?
The ultrasound. What? Your ultrasound is okay.
Mark Reiner, you need to go to mute.
Okay, I will.
Sorry.
Okay, is that working for everybody?
Yep.
Hi, I'm Ji and I'm one of the PGY4 fellows. My case is much more basic than Yu Yang, much more bread and butter. So this I came across during one of my calls. 52-year-old gentleman with hypertension, diabetes, and STEMI, PCI in 2014, had a screening colonoscopy in a few days ago, and then had 4 polyps removed of various sizes between 10 and 5 millimeters. Presents 3 days later with many episodes of maroon stool. His medications include prasugrel, lisinopril, metformin, and then all of his diabetic medications. He is hemodynamically stable, but his hemoglobin has dropped from 13 to 16 grams per deciliter about a month ago. So we do a colonoscopy. Actually, this was during the weekends. It was in the OR, fairly poorly prepped, but we did find sites including a visible vessel. We identified all the polypectomy sites. In the ascending colon, we had a site with active bleeding, descending colon with visible vessel, under an adherent clot. And we clipped the sites to achieve hemostasis, and the patient was safely discharged. So the topic I wanted to talk about was post-polypectomy bleeding. I guess it's more for the first-year fellows, but it occurs in about 1 in 100 patients who undergo colonoscopy and polypectomy, compared to 0.6 in 1,000 patients who do not undergo polypectomy during their colonoscopy. It can be divided into 2 categories. There's immediate bleeding, which occurs during the procedure before the patient leaves the endoscopy unit. And this is usually not a problem because it's identified during the procedure and hemostasis is achieved. Delayed bleeding is the more problematic aspect. It's thought to be caused by sloughing of the eschar that covered the blood vessel and increasing necrosis after cautery, so the spread of the damage. The risk factors for delayed post-polypectomy bleeding include the polyp size, so estimated for about 1% of polyps less than 10 millimeters, but 6.5% for polyps greater than 20 millimeters. And this is a significant risk considering that, your patients with who undergo polypectomies do not necessarily just have the one polyp site that is treated. A location of the right colon or cecum polypectomy site is also a higher risk, and then needing to resume anticoagulation after the polypectomy. Usually presents 5 to 7 days after the procedure, hematochezia, maroon stool, but it can be hours to weeks later. The prevention of post-polypectomy bleeding was something I thought was interesting. Obviously, we do management of anticoagulation, antiplatelet agents according to the ASU guidelines that everyone's familiar with. there does not appear to be official recommendations regarding, what technique to use in terms of polypectomy, at least from what I found. But polyps less than 1 centimeter, it is suggested that cold forceps or snare polypectomy may have a lower risk of delayed bleeding. Whereas in polyps greater than 1 centimeter, you should consider use of prophylactic hemostatic clips, especially if the patient has polyps greater than 2 centimeters, coagulopathy, or the need to resume anticoagulation after the procedure. I thought we would look at just a couple of studies on which this is founded. So this was, I think, published in 2018. It's a randomized controlled multi-centered non-inferiority trial. The outcome actually is rate of complete resection between cold snare polypectomy and hot snare polypectomy, and it was found to be non-inferior. Despite having 538 patients, the rate of bleeding was actually very, very low. I think there were only like 4 patients who had delayed bleeding afterwards, but they only occurred in the hot snare polypectomy group. The data for with the outcome specifically for delayed bleeding is much less good quality than looking at resection rates. So this is a retrospective cohort propensity match analysis of 530 patients with various ranges of polyp size, but not the big ones, with delayed bleeding here occurring in 4 patients in the hot snare polypectomy and none in the CSP group. So similar results to the prior study, with reduced rate of bleeding in the cold snare polypectomy group. So a couple of take-home points. Bleeding can be immediate or delayed. It usually occurs 5 to 7 days after polypectomy. And the risk factors include 10 millimeter size polyp or greater, right colon, resumption of anticoagulation. The cold snare polypectomy appears to have a lower delayed bleeding rate. And this was specifically studied in the 5 to 10 millimeter group. And then consideration of prophylactic hemostatic clips for large polyps with risk factors, including anticoagulation greater than 20 millimeter. I've seen various things being done. I've seen larger polyps being taken out without consideration of hemostatic clips. So it would be really useful to have someone comment on what your considerations are when you do these to prevent bleeding down the line.
Okay. Thank you very much, Jiyun. I think one point I would hammer home is that while Jiyun mentioned that delayed bleeding usually occurs 5 to 7 days after a polypectomy, it is well known that it can occur up to 2 weeks after polypectomy. So, especially if your patients are having larger polyps removed or piecemeal EMR, that sort of thing, we always counsel our patients that they need to be aware of bleeding risk that can occur up to 10 to 14 days out. So if you are planning on performing something like that on a patient, you may want to counsel them pre-procedure that they should not be doing this, 2 days. They should not be having their colonoscopy and polypectomy 2 days before a trip to the Amazon or, before a family wedding or something important, because bad things can happen, unfortunately.
We see the same thing in general surgery. It's not uncommon they can have an acute bleed within 24 hours after a bowel resection, and then they'll be perfectly fine. And on the 7th to 10th day, they'll bleed from either sloughing of the suture line or a scab coming off. So we see the exact same thing surgically, and timing is the same.
Jiyun, did you come across any data on the role or utility of follow-up colonoscopy in patients who present with post-polypectomy bleeding? In other words, someone comes to the ED 3 or 4 days out and they're hemodynamically stable. Should we be doing colonoscopies on all these patients, or is there a role for just sort of monitoring?
I'm not sure. I'm not sure about the data behind that. That would be really interesting to look at. Yeah.
And I think some of the big societies have put out recommendations. I don't know, Dave, you can comment that if a patient's clinically stable and the bleeding spontaneously resolves, that you can just safely monitor them conservatively and not have to repeat a colonoscopy, as is not uncommon a case. By the time the patient gets prepped and a colonoscopy is performed and you get in there and find the site, it's probably already not bleeding anymore. And you can always do, cautery or clips to prophylact against rebleeding, but there are good studies and data out there that show that stable patients can be monitored without need for reintervention. But I think the important thing to stress to patients is that it's impossible to predict which patient will fall in that category. And it's always, these patients should always be encouraged to come seek medical attention in an emergency room or an urgent care for vital signs and monitoring of their hemoglobin, et cetera. And I think patients get frustrated with that because they're like, well, I bled and it stopped and I feel fine now. And it's like, well, it could have been a sentinel bleed. You're right. Maybe it did stop. We have no way of really knowing. So I don't know, Dave, do you have any comments?
The key discriminator in the stuff that's been published recently, this seems so obvious, but is whether they're having rectal bleeding at the time that you're seeing them. So if they're having rectal bleeding, obviously something's still bleeding, but more important is the converse, which is that if they're not having rectal bleeding, they're bleeding and they're hemodynamically stable, their bleeding has stopped, and the utility of then going in and trying to look for an intervention goes down dramatically. You don't need to do it. So, you need to either act quickly, but if they stop on their own, you can feel pretty comfortable that they've stopped. That's the crux of the guidelines and the data now.
Is that even for patients who are on anticoagulation? They don't have a risk of rebleeding if they've stopped on their own?
They always have a risk of rebleeding again kind of thing, but typically, they're going, that once they've stopped, they've stopped. The management of anticoagulation, antiplatelet agents in this setting is really complicated, and it's a risk-benefit thing. I mean, sometimes you do need to interrupt the anticoagulation again and let things settle down. But again, it has to do with the indications for why, and it needs to be individualized, and everybody needs to be a good clinician at that point.
I think the last point we'll sort of talk about, which you mentioned, Ji-Yoon, is about the role of clipping. For anyone who's ever heard Jerry talk about this, or on Friday morning conference, anytime Jerry took out a big polyp, we would always ask him, did you clip it? And he'd always give one of his trademark, nah, don't need to do that. And for 50 years, he was right. But now there's this whole plethora of prospective data showing, and again, Ji-Yoon mentioned this, that patients who have large polyps removed, particularly greater than 2 centimeters, and particularly in the right side, so cecum, ascending colon, and proximal transverse colon, there seems to be a significant, statistically significant benefit to decreased bleeding rates when you do prophylactic clipping. So I think that is becoming the standard of care. The challenge is that if it's a very large site, you often cannot close the entire defect. And there's one study that shows that partial closure is just the same as doing no closure. And that full closure is really where the benefit comes. So, when we do these big piecemeal polypectomies in the cecum and ascending colon, sometimes the defect is 5 or 6 centimeters, and there's no utility in trying to close that because you're just not going to be able to do it. It's usually too big to oppose the edges, and you end up placing like 5 or 7 clips, and it's like, well, I guess we got a third of it closed, but we really probably clinically didn't really do anything significant. But that is really where the main crux of clipping comes in, is large polyps, right side, and I think as mentioned, patients who are at high risk for rebleeding because of anticoagulation. I think we should be considering clipping those patients, clipping the resection site. Any other thoughts or comments? A very common and important topic.
I will comment that the data for prophylactic clipping is kind of all over the place. It's like every 6 months or a year. I mean, the data is getting more rigorous. It used to be case series, and now we're moving towards RCTs. I think the most recent RCT showed no benefit to clipping, but the one in the same issue of gastroenterology, or the one prior, showed there was a benefit. And some of it comes down to how you clip. And I agree, these big defects, like I think you end up creating more trouble than you do help the patient when you start to try to close these huge areas. But we've all scoped post-polypectomy bleed patients and seen the visible vessel between two clips. You know, you got clip, and then vessel in the middle. And that speaks to the technique of clipping, which if you were just taking that clip and just dragging the mucosa over top the defect, you haven't done anything. You literally have to sort of evert the submucosal tissue and kind of like get it to kind of close up like this. And what that does is it actually closes the submucosal vessels, and that's harder to do. And the other thing that's important is how close your clips are to each other. I think Doug Rex or somebody from a couple of years ago at DDW talked about this. If your clips are further apart, you're less likely to actually achieve a benefit in preventing bleeding. And you know, it starts to get to be an insanely expensive and complicated thing to do clips really close together to make like the Great Wall of clips in the ascending colon. So there's a lot more to come, I think, in terms of techniques and how to do it. I think that's why the data is all over the place. But if you're going to try to do it, you don't want to just literally like just pull the mucosa over top, just like you're taking a bed sheet and covering like a big mess on your couch. You really want to try to get in there and get deep into the submucosa and close in some of the small vessels underneath.
Just to follow up comment on that, I agree completely, Satish. With ulcer bleeding, you know, we're always focused on the visible vessel that's there, but that's technically not where we want to be clipping. We want to clip on either side of the visible vessel because that's what's feeding bleeding through the pseudoaneurysm and the vessel. So I think it's something that we probably don't talk about as much or enough. And no, I agree. I think there's an art to placing clips, and if you don't do it right, you end up causing more damage than good sometimes. So cool. All right, well, great case. Thank you, Ji-Yoon. Great conversation and discussion. I believe Nick is still on. Nick, do you have a case to present today?
I do. And
Excellent.
Here it is. Endoscopic whack-a-mole. This is actually in keeping with the theme of the other cases. It's actually a bleed case, which I rarely present, but this one was particularly interesting. So the case is actually a pediatric case, and I don't know if any of our pediatric colleagues are on here, but thank you to them for allowing me to share this. The patient was 16-year-old female. She presented with an initial presentation of diabetes with diabetic ketoacidosis, and she just had a very dramatic course. Unfortunately, she was in the ICU. She had renal failure. I think she had VFib, pancreatitis, rhabdomyolysis, basically very sick in the ICU. And in this setting, she had hematemesis, and that was the original reason for the consult. It was a little unusual. It was sort of a dramatic hematemesis, blood with clots, and then it would just stop. And she required transfusions intermittently, and they were sort of watching to try to see how this was going to play out. Ultimately, they made the decision to proceed with endoscopy. And what we encountered was a lot of blood and fresh blood, and there was basically no visibility. We didn't see any lesions. All we could see was blood. So the first step was we actually took the patient and rotated her from left lateral to right lateral. And this moved the blood within the stomach to allow visualization under that pool. At this point, we were scoping across the bed. And then we were able to clean up, and we saw this. So she has a spurting vessel in the absence of any lesion. There's really no ulcer. And just with minimal trauma, just the lavage, it basically just starts hemorrhaging. And so the decision at this point was made to attempt to close it with clips. This was very challenging, thus the title. But basically, we're in retroflexion. The patient is right lateral. We're across the bed. The visualization is poor because there's no lesion, just the vessel and blood. So the technique is sort of to try to tamponade the vessel with the clip before you deploy it and see if you're in the right spot and see if it's still bleeding or if it stops. And then ultimately try to basically catch it in one of these clips. And as you can see here, it's very challenging. The second you get close enough to put the clip on, you're sort of in the puddle of blood. Ultimately, this clip was placed in the place where we thought the vessel was. You can see where agitating the area. There's no more bleeding, and this clip is deployed. But unfortunately, that's actually not where the vessel was at all. And it's actually over here, this ongoing bleeding, which is very frustrating. So further clips are deployed. Another one sort of closer, but right on the edge. This next one, I think actually you can still see the spurting there. This one is right on the vessel. And ultimately you can see with, again, with irritation, agitation, the bleeding is stopped with this clip.
Any
and then
thought
one further one is
injecting epinephrine at this point to get control?
Yes.
And then
So I think that's a valid thought, and we'll talk about treatment of Dieulafoys in general, which is what this is. Similar to ulcer bleeds, combination therapy is better than single modal therapy. In this case, I think that you could take it either way. The epi might help you, it might hurt you. You want visualization, but if you inject epi and it stops bleeding, then you don't know where the vessel is. So I think it could be a double-edged sword. Probably epi wouldn't be enough to stop it bleeding completely, so it might work out to just slow it down and you would still be able to locate it. But that was one of the concerns with injecting epi, is that we would just lose it completely and not be able to get a really definitive treatment. And the patient did great after this. She just stopped bleeding. She was still in the ICU for a little while, but she stabilized, and then she went to acute rehab. So we can talk about Dieulafoys. The pathophysiology of a Dieulafoy is it's basically an aberrant submucosal vessel that perforates through the mucosa in the absence of any clear mucosal defect like an ulcer. And the vessels are huge. It says 1 to 3 diameters, which doesn't sound that big, but these mucosal vessels should be capillaries at this point. They should have branched off into something an order of magnitude smaller than that. But these do not, for whatever reason. And so they are very large vessels that get to the mucosal layer and then bleed very dramatically. The presentation is actually not our patient. The typical patient is usually an older male with multiple comorbidities. NSAID use has been associated with bleeding. They are found often in the location that we saw this lesion, in the proximal stomach. About 74% of them are in the stomach. They can be seen in the duodenum, and they can really be seen anywhere in the GI tract, but it's very rare to see them elsewhere. They present with upper GI bleed, and classically hematemesis, similar to the way this patient presented, with a sort of stuttering bleed. They might start and stop as the vessel bleeds and then just stops spontaneously. In the study I saw, it said it accounted for 1 to 5.8% of upper GI bleeds. In my experience, I've barely seen a single-digit number of these. So I don't know if that seems like an overestimate to me. But treatment is with endoscopy. It can be very tricky because there's no lesion, and so if you don't catch it while it's bleeding, then you might not see the lesion at all, and it may require multiple sessions. So the key is that you have to scope them quickly while they're bleeding so that you don't miss it. Endoscopic therapy, as we discussed, is similar to ulcer disease. You can use any of the typical methods that we use endoscopically, and combined therapy is more durable than just solo therapy with injection. EUS can actually be used in these cases to locate the lesion. On the right, this is all black and white, kind of hard to see, but there is basically a vessel at that big arrow that is penetrating through the muscle layer and into the submucosal layer. And the other utility of EUS, and specifically Doppler in this case, would be that you could Doppler the vessel to see that it's bleeding and locate it. And then after treatment, you could Doppler it to confirm that there's no longer blood flow and that you've successfully treated it. And if endoscopy is unsuccessful, as usual, angiography or surgery, similar to ulcer bleeds, could be used. That's it.
So,
Who was Dieulafoy?
Dieulafoy was not the first guy to discover this lesion. It was some other doctor who only reported 1, and then Dieulafoy reported 3 or 4, and he got his name on it. So I guess that's the trick.
I think he was like a French surgeon in the late century, and I think his big claim to fame was like appendicitis or something like that. But yes, he saw multiple ones of these.
There are 2 aspects of the case that I thought were useful and to discuss. And I talk about this with the fellows anytime I'm on service. I'm a big fan of the rotisserie approach to patient positioning. When a patient is left lateral, the dependent part of the stomach is that fundus. And if you just imagine a little like Netter's diagram and turn it left lateral. So, and that's what you see anytime you throw water in the stomach, everything pools towards the fundus. And if there's a large volume, it's fundus all the way up to the cardia. And we tried to suction this out. I mean, it was clot. I mean, this thing was bleeding and clotting like the whole time. And so when you turn the patient right side down and distend the stomach, the dependent portion actually becomes the antrum. And so we literally would inflate the stomach and this big massive clot went flump and like just dropped into the antrum. And we had an incredible view of the entire fundus. So I don't spend a lot of time when I'm doing bleed cases. If there's a big clot in the fundus, I just turn the patient. It's an annoying position to scope, but I've saved hours, even on call, even in the ICU, wherever. It just makes your life better. It is trickier to scope, but you can do it. This was one of the best Dieulafoy examples I've ever seen. We actually cleaned the fundus completely and there was nothing there. There was no blood. And we're like, how is that physically possible? And then we're just spraying with water and we hit one spot and just Old Faithful went off. And it was really impressive. I mean, so epi in this sense would have been really tough because there was literally nothing. We're staring at a clean fundus and then it just blew up out of the submucosa. And so we had talked about it. I was a little worried and the positioning was really pretty bad. But really take advantage of the endoscopic rotisserie. And fellows try to convince your attendings to do this. It really can save you quite a bit of time.
So just to jump off of that, I agree, but an even easier technique is just to sit the patient vertically, 45-degree angle or higher.
We did that.
Obviously, what's that?
We tried that first.
Yeah, so obviously these patients should be intubated, a patient like this. That way you can take your own pulse, the situation is controlled, and the patient has their airway protected. Because not just blood, but you see all the fluid being instilled. So there's a high risk of aspiration. But yes, the other cheap way and easier way without having to rotate the patient is just to lift the head of the bed. I scoped somebody with a variceal bleed sitting up. They were intubated, but it was the only way to maintain visualization and just have blood go into the stomach and not pool in the esophagus. So it could be a similar approach here, but very nice, very good thought for sure. Very nice case.
One other quick thing, Chris, while we have it. I mean, I agree with the turning stuff that you guys are talking about. Therapy for this, I think there's recent stuff that would suggest that large things like over the scope clips or band ligation is actually potentially more effective than superficial techniques. And it sort of makes sense if you think back to Nick's histology picture that he showed. What do you guys think?
I have to imagine an over the scope clip would have been impossible in this position.
Correct.
If you can, in other areas, if you can see it, if you could get to the area, certainly you could do it. But the nature of these things is they're just hard to visualize, right? They're briskly bleeding or there's nothing there at all. It's sort of an annoying dichotomy.
And usually, Nick, maybe you mentioned this or came across it. Like you said, these are typically like the person walking on the street doesn't get these. It's usually somebody who's really sick.
Yeah, it's 100%. It's usually a sicker older person.
It's interesting. The old literature talks about Cushing's ulcers and Curling's ulcers. And, Curling's ulcers were supposed to be with burns and Cushing's ulcers with head trauma. This patient had cerebral edema. And so I thought you were going to get at an ulcer, but I wonder whether the old literature was really dealing with Dieulafoy's altogether. Who knows?
You may be right.
All right, fantastic. Thanks so much, Nick. Thanks everybody for the lively conversation.